then I can close.
Hi, Dr. Yahya. Can I ask a question? In case of upper respiratory tract infection,
Okay.
if you receive a case of upper respiratory tract infection, what
Okay.
you are doing to consider this is an bacterial or viral infection? We know it is commonly it is viral, but in our situation here, there is a lot of cases is coming with bacterial infection, and if we are not starting with an antibiotic, then we found patients came with complication.
Okay.
So what is the best way to?
It depends on the age. So what I do is I treat at the age. So if it's less than few months, viral or bacterial, I admit, then I can send for cultures, and also for viral panel, we do 15 viral panel culture. So if you don't have, then I would start antibiotics and follow clinically if you don't have cultures. And I do between 2 months and from 2 months to 3 months, I would use the risk factors. So there is a criteria for this factor. I would use the white BC count if they are more than 15 or less than 5,000. So if they are more than 15, less than 5,000, I would give antibiotics, even if I know it's an. If you have uncooperative parent or a parent who have no resources, you cannot follow up, I would give antibiotics. If you have a history of prematurity, history of neonatal infection, history of death, I would give antibiotics. If there is no term baby, fever is less than 40 or less than 39, I would say. White BC between 5 and 15,000. Normal inflammatory markers, CRP and ESR, I would just observe. So I do CBC, ESR, antiviral, and I'm sure that the parents are cooperative and they have access to healthcare. I would give them 48 hours and then check again.
Okay.
If the patient is more than 3, between 3 and 36, then probably you can wait. So it depends if the patient is sick, if the patient, there is risk factor. So you have 2 options. If the patient is not sick, but you have like let's say white BC more than 15,000, I would give 1 dose of ceftriaxone and check after 24 hours, after 48 hours. If the patient is not sick and all the risk factors, no history of death, no history of prematurity, no history of white BC is between 5,000 and 15,000, then I would just observe, give antiviral, send home. If the baby is okay, but there is a risk factor, I would give 1 dose of ceftriaxone and then check after 48 hours. If a patient is sick, no question, admit antibiotics, even if it's viral infection. The only way, because clinically you can sometimes differentiate between viral and bacterial, but the only way is you do blood culture, 2 sites, negative, CRP or inflammatory marker dropper, like white BC, like CRP, like ESR. And you said also viral panel, but also, from the community that, your community, there is like epidemic or pandemic of viral infection. You have to be very cautious when you decide to give antibiotics or not. You don't need to use it because 90% of infection are viral, but these are the compromise. So, for example, and as you know that we go by number need to treat and number need to harm. So and what is the incidence of sepsis? Because what we are looking here is a sepsis. So for a patient between 3 months and 36 months, and if for patients between 3 months and 36 months, and there is no risk factor, the incidence of sepsis, the likelihood of sepsis is 0.5. So to treat one sepsis, you need to give antibiotics for 200 patients. But if you have risk factor between 3 months and 36 months of infection, the likelihood is 5 to 10%. So you need to treat 10 to 20 to treat one sepsis. So that's become cost effective.
Yes.
So it depends on. Also remember side effect of antibiotics, resistance, and so on. And don't tell me cost is not important. Cost is important for patients in Iraq because I think the patient pay for the medication. So. Yeah.
What about the diarrhea associated antibiotic? Now some practice they are giving probiotic with the.
Oh, nothing wrong with giving probiotics. I don't advise because
they give with antibiotic. And once you're starting the antibiotic, they
no need because you are killing them. But when you can use the prebiotics, which is the food. But when you give antibiotics, you are killing the bacteria, with the good and bad bacteria. So giving probiotics with antibiotics make no sense. So when we give probiotics, but when we start antibiotics and do sepsis workup, we stop the probiotics. Believe it or not, we have two facilities here. Between them is the river, so you drive between them 15 minutes. One of them using probiotics, the other one is not. So if you ask why, nobody knows why, and it's just the trend. But when you start antibiotics, you have to stop the probiotics. You can continue, but what's the point?
Okay, what about the duration of antibiotic? There is, especially in otitis media and acute pharyngitis and tonsillitis, there is two also about 3, 5, 7 days.
Well, all the antibiotics in general, whatever the reason, you have to do blood culture within 48 hours. And if blood culture is negative, you have to stop the antibiotics. Sometimes you have a clinical deterioration or no change of the clinical status and blood culture is negative, I would continue for 5 days. But if your culture is positive, you continue antibiotics and repeat the blood culture every 48 hours until the blood culture is negative.
Actually, in our practice, we are not doing blood culture. We are prescribing the antibiotic and we need to inform the patient for 3 days, for 5 days, or 7 days.
Are you talking about outside? You're not admitting
the patient.
If you're not admitting the patient, probably the patient is not sick.
No, I mean, we keep him on oral antibiotic. I want to just...
No, I got that. When you send a patient to home, it depends on the age. When you send the patient to home, your patient is not sick, right?
Yes.
Because if your patient is sick, you have to admit. Now, so we are talking a patient is not sick. So if the patient is not sick for otitis media, I would give it for 5 days. That's my practice. If it's pneumonia, I would give it for 7 days. But usually when I prescribe antibiotics, I check my patient after 48 hours. As you know that otitis media most commonly is viral infection, or you have the 3 common bacteria, which is the Haemophilus, the Strep, or the Moraxella. So, and usually they become sick. So if your patient is not sick, I personally give the antibiotics for 2 days and then examine. If there is no change, I usually stop the antibiotics. If there was like mom is telling me there is improvement, I would continue for another 3 days and check after 3 days and then stop the antibiotics. Now, most of time, 90%, you're using useless antibiotics. But the best way is to do culture, of course. If culture is negative after 48 hours, I would stop. So I rarely ever have a patient without blood culture when I treat otitis media. Go ahead, sorry.
What about the practice of giving 3 days single injection ceftriaxone for 3 days?
This is only indicated when your patient between 3 weeks and 36 weeks, and you have a risk factor and the patient is clinically okay. What I mean by risk factor, your white BC more than 15 or less than 5,000, your CRP or ASR is high, you have a family history of death, you have a history of neonatal admission, you have history of previous admission, you are premature, you have complicated labors, patient receive antibiotics in neonatal period, patient also, mom has risk for GPS, not treated, mom has UTI. So if you have a risk factor, but the patient is okay, and he's between 3 and 36 months, I give 1 dose and I check the patient after. I give 1 dose of ceftriaxone and check the patient after 2 days. If the patient is less than 2 months and risk factor, even if clinically okay, I would admit. The reason for that, because between 2 months and 3 months, the risk of neonatal sepsis in risk factors is up to 5%, while the risk factor or with risk factor, well, the possibility of sepsis in patient more than 3 months is the risk factor for sepsis is less, and that's the reason why you observe and give 1 dose antibiotics. So neonatal period, like from 1 to 2 months, no matter what, admit antibiotics, absolutely. Between 2 months and 3 months, I would do risk factor. If you have a risk factor, and even if the patient is okay, between 2 months, I admit antibiotics. If the risk factor is okay, between 2 months and 3 months, and the patient clinically is okay, I send home. I don't do anything. If more than 3 months and the patient risk factor is okay, clinically is okay, I observe, check after 24 hours. If he's okay, but there is risk factor, I give 1 dose, check after 48 hours. If he's sick, I admit and IV antibiotics with blood culture.
Okay.
Is that,
thank you, sir.
Is that the answer for your question? Or?
Yeah. Thank you. Thank you.
Hello.
Any more questions?
Dr. Yahya, I have a question. We are now really, hello, you are hearing me?
I do hear you.
Yeah, okay. We are here, really, it is a bad practice, overuse of antibiotics.
Yeah.
And we use misuse of antibiotics also. And we are used to use ceftriaxone in simple cases, really. Yeah, most of the doctors, they are practicing to give ceftriaxone in spite of other less stage or degree of antibiotics, so that there is much resistance. Now we are creating more resistance to the.
Well, there is one now in the world, what we call it superbug. The superbug is the bacteria that is resistant for everything. So it's more dangerous than tuberculosis and MRSA. Yeah, resistant antibiotics we do not have in North America because patient can complain to the college and your license can be suspended easily. The patient here is have all the right, doctors have no right. The only right that you have here is to defend yourself.
Yes,
so the antibiotic use is a problem.
We have no policy here in Iraq. We have no standard policy to use the antibiotics. It should be for a simpler infection to use, for example, amoxicillin.
You have to divide the patient to have high risk, low risk.
Yeah.
High risk, and observe. Low risk, that's all. Patient sick, admit and give antibiotics. That's your division. And we're talking about after 3 months, because 1 and 3 months, I don't know, Kenny? I don't know who's like, there is a background. I don't know. You can mute yourself because.
I don't know about.
Whoever was asking, just unmute yourself because I muted everybody. I don't know who was talking, so unmute yourself and continue, please. Mason, do you have a question? Mason, do you have
No, thank you.
Okay, you're raising your hand.
Hello, assalamu alaikum.
Thank you, Doctor.
Thank you very much. Alaikum assalam.
Please, Dr. Yahya. According to sickle cell patient
Okay.
with fever,
Okay.
he went to start the antibiotic according to the fever.
Right away.
Mm.
Sickle cell, fever, admit antibiotics. IV fluid, narcotics, treat, admit antibiotics. No question about that. Do blood culture, negative, stop antibiotics.
Yes.
No markers, no risk factors. Sickle cell, fever, admit. Right away. No question about that.
Yes.
Whatever age, whatever sickle cell, fever, whatever the cause, even if it's obvious, viral, admit, antibiotics, do blood culture, and then IV fluid, narcotics, treat, very serious. Pain are very severe, risk of sepsis are very high, and very serious infection. So sickle cell, fever, admit, antibiotics, no question.
Yes. Thanks.
Thank you.
Hello, Doctor. Good evening, sir.
Good evening, sir.
My name is Dr. Ben from Nigeria. Thank you for the presentation. I have a question.
Go ahead.
My question is for neonatal sepsis.
Okay.
How long do you administer antibiotics?
It depends. As I say, we start for like all patients who have a risk factor of infection, like prematurity.
Okay.
As you know, prematurity can cause by infection. So delivery can cause by infection. But let's say if a prematurity due to C-section for maternal reason, we do not start antibiotics. But prematurity per se, transient tachypnea, if you have a clean section with tachypnea and respiratory distress, we do not start antibiotics. If you have a clean section and prematurity and respiratory, we do not start antibiotics. But otherwise, we start prophylactic antibiotics. So if you're talking about prophylactic antibiotics, then it's 2 days, 48 hours. We give 2 doses of gentamicin, 1 dose of gentamicin, and we give 3 doses of ampicillin at birth, at 12, at 24, and at 36 hours.
Okay.
And then we stop if the culture is negative.
Okay.
If for the early sepsis, we are treating early sepsis, we're giving prophylaxis to treat presumed early sepsis. We do 1 site culture. After 48 hours, we do 2 sites culture. So it depends on what you're treating. Now, if there is a very high risk of infection, let's say mom has UTI, E. coli not treated, or mom has offensive liquor, or have tenderness, or have leukocytosis, and prematurity with respiratory distress. You gave antibiotics, and your culture is negative. I personally would continue for 5 days. Okay. If the culture is negative, then I stop antibiotics if there is not like major risk factors. If the culture is positive, no, it depends. For strep, I would continue antibiotics until I have culture negative, and I give antibiotics 5 to 7 days after the last culture negative. So let's say you have GPS infection, and I'm giving ampicillin, gentamicin. As usually with GPS, we switch to penicillin, and then we continue. And then we do cultures every 48 hours. When you have a culture negative, from that, I would continue 5 to 7 days, depend on the situation. For more serious infection like gram-negative, I might go longer.
Okay.
But we're talking about if the culture is negative, and there is no major, that's just prematurity. But mom have no GPS, or have a GPS untreated with intrapartum antibiotics, appropriate. You have no prolonged premature rupture of membrane. You don't have history of infection. You don't have maternal leukocytosis, no maternal fever, no maternal tenderness. Respiratory-wise, you gave surfactant and the patient respond. Patient clinically otherwise okay, no abdominal distension, no risk of neck, all this sort of thing. If nothing and the culture is negative, I would stop antibiotics right away. Now, if you have a problem, because we know 50% of sepsis are culture negative, the reason is either you didn't catch the infection because you're taking sample like 0.2 ml or 1 ml in most cases. You didn't get infection in that, or the infection was in a growing phase. So sometime in a culture, we know that. How we know? Because the whole idea is, what is the risk of sepsis? and how many patients you treat to get one sepsis. So the number need to treat. So if the number of need treat is less than 20, then it deserves the antibiotics. If it's more than, when it's a number of need 20, when you have risk factor. So when I have risk factor and let's say very high ESR or CRP, and I did the CRP after 24 hours and it's rising, but the culture is negative. I have white BC less than 5,000, the culture is negative. I might continue to 5 days. But if the culture is negative and I have no risk factor, I will stop right away. If the culture is positive, then I repeat the culture every 48 hours until I get negative. If from that day, I would continue from 5 up to 14 days. It depends on the type of antibiotics.
On the organism, okay.
Dr. Yahya, just I want to say that last month in August,
Thank you very much.
National Institute of Health and Care Excellency, the NICE, just brought a new guideline on antimicrobial use, and it is for review by professional to send their comment. So anyone can enter NICE and look on this guideline. It is just new last month, August, and you can send your comment and review to the organization.
As you know, the practices are changing previously, and now all depend on the risk factor and the age group.
Yeah. This is the last. Latest,
it all depends on the number need to treat. So if the risk of sepsis is less in less risk patient, then the likelihood of benefit of antibiotics are very low. And also you have to take your community. Like,
yes, this is exactly.
Is your patient have access to healthcare? Do you think that they can come overnight? Do you think that they are good? Are they illiterate, or they are educated parents, so they can observe, and when the patient deteriorates, they can go. And if they go to the hospital or the health institute, will they get the care? So you have to determine that. And I always give a number overnight to call somebody when the patient deteriorates, if I decided not to give antibiotics and it's a critical age group. So the use of antibiotics is very subjective. So you have to consider the possibility of developing the resistance. So it's good to comment, but I would say even if the guideline change, it's all subjective and prone to your judgment call.
Thank you.
Thank you very much. Any more questions? So I will pause the video, the lecture, and then I will pose the questions if somebody want to listen with some time. And happy to have some of you attended, and we'll meet I will be in Iraq on September 5th, and I will be in Dubai on September 23rd. I will be in Bahrain on October 1st.
November 15th.
November 1st, and I might be also in Egypt. I have long trip to share with. So I will do workshop ventilation, waiting the names so I can forward the resources. I also will give two talks in Erbil. I will give one talk in Dubai and also 3 workshops. And also I will give 1 talk in Bahrain and 1 workshop. I might also go to Saudi Arabia. So hope to see some of you there, and we might do another talk before I go. I will travel on September 5th, so I might also do TPN, but I'm not sure. I'm not ready yet.
When in Saudi Arabia? Sorry?
In Saudi Arabia, I am not 100% sure. I think I will do locum in October for 1 month. And also I will participate. I do contactless imaging. So there was a promise that they will fund my research. And so if that happens, because I need money, I might go to 1 year or 2 years in Saudi Arabia to do my research about visible light imaging, thermal imaging. I don't know, you guys, if you know, leap motion, Kinect, and also CGI. So I'm using the visible light, the usual camera, to measure the blood pressure, heart rate, and cardiac output. And working on that project, they need lots of money. So if they do that, the plan is to go for 1 month as a locum. So I might extend to 1 or 2 years, get leave from here, unpaid, and go there. But we'll see. I'm not sure. But I think I will go for locum. Any more questions?
I am in Dammam, inshallah. I wish you يعني, all the best, inshallah.
In Dammam, I think the hospital in Dammam that they called me. I think it's called King something. King. There is a complex. Can you remind me the complex? King.
Yeah, yes, I know.
Forget the name. I'm sorry, but it's a complex.
The Mom Tower. The Mom Tower, like this.
No, the hospital. There is like a big hospital, a complex hospital, more than one building. Is that right?
Yes.
Yeah, I think that hospital. I forget the name, but I have it in my email. But I was chatting with somebody. Sorry, because it's too much this 2 months, so I'm just trying to organize my time. But I hope to see you. I mean, if I see there, I will post on the group, and hope to see some of you there. Okay, any more questions?
Yes, Dr. I have only one question.
Okay, well, first, are you the iPhone?
Yes, I am the iPhone, and this is my first.
Good. So if you can kindly next time change your phone, because your iPhone, I don't know your name, I don't know. So if you can introduce yourself. Hello? Hello? iPhone? Hello? You guys hear me? Hello? iPhone?
Hello, yes?
Yeah, go ahead, ask question.
All right. Thank you very much. I will introduce myself one more time. I'm not sure if you caught my name. My name is Khalid Abdel Hafiz. Khalid Abdel Hafiz. Yeah, thank you very much for you. So firstly, I really thank you for your lecture. It's very valuable. My only question is, recently we have been treating many patients for viral meningitis plus the bacterial meningitis, and the reason why we suspected the viral meningitis is just because the way they looked initially on the admission. And sometimes we find it very difficult to perform the lumbar puncture on such patients because of many, sometimes it's the complex needs, and just because I'm working in a district general hospital, the anesthesia is not always available. So my question is, if we are using the polymerase chain reaction, the PCR, for herpes, HSV, how valid it is in ruling in and ruling out viral meningitis, and how herpes, can that be useful?
Herpes or viral in general?
Sorry. So it's mainly the herpes, and why is that? Because the acyclovir, you might know, the acyclovir is really one of the medications that can cost us the IV access.
Okay. So the question is, I didn't catch it very well. You have you're suspecting meningitis. You don't know whether it's viral or bacterial, and you admitted the patient, and for some reason you couldn't do the lumbar puncture, whether the patient is difficult or sick, or you have no facility to do anesthesia. So the question is, what type of antibiotics and what is the duration? Is that correct or I'm wrong? Is that the question? Is that your question?
also, my question is, if we do PCR, polymerase chain reaction, for viral virals, including for the viral panel, including the HSV, can we avoid doing the LB then?
No.
Oh.
No, because even if it's positive, so let's say not herpes, let's say a bacteria, and let's say you did blood culture and it's positive. Now, would you treat it as sepsis or meningitis? Because you know the doses are different and durations are different.
Absolutely, yeah.
So if let's say it's bacteria, not herpes. So if it's sepsis, then the duration is different. So to decide about the duration, then on a type of the antibiotics, then you need lumbar puncture, and you need more than one lumbar puncture. You can't depend on one. You have to do lumbar puncture, and if it's positive, you have to repeat it until it's negative. So it's like a blood culture. With each lumbar puncture, you have to do 2 sites blood culture each time, because you need to know now your sepsis or meningitis. Now for herpes, I would treat right away, even if it's negative. If I have a good suspicion, a risk, or clinical suspicion, because the side effects are not high, but the consequences of herpes, I'm assuming you mean encephalitis, not meningitis.
Encephalitis more.
Yeah, because it's encephalitis. The consequences are disastrous. So I personally, if herpes crossed my mind, I would treat. And as you know, herpes are of 3 types. So it depends. Meningitis is like sepsis, like intensive, or it's mucocutaneous. So it depends on the type. You have to decide. But if it's meningitis, so what we do swabs. Okay. And then for PCR, and we do lumbar puncture PCR. So we do usually nose, umbilicus, ear, mouth, and anus swabs. They call it cervix swab. If it's neonate, we have to do it after 24 hours, because before 24 hours, mostly it's contamination. Lumbar puncture is super important. If meningitis cross your mind, then lumbar puncture is indicated. There is no contraindication of meningitis other than cooning or increased intracranial pressure, which is very unlikely, or the patient is very sick, or you have a coagulation problem, or you have a local problem at the Now, if you cannot do it, then you have to use your judgment call. Is this meningitis? Then I would go with the dose and duration of meningitis, despite the blood culture is negative. And also it depends, you have an access, like IV access, is the patient can be admitted, how long you can admit it, what is the cost? But really you have to decide. But if it's herpes, then acyclovir right away.
And for how long, Dr. Yahya, do you think the acyclovir would be, if we are treating a viral encephalitis or viral?
6 weeks.
6 weeks?
6 weeks, yes.
All right. And also the oral acyclovir.
As you say, the result is disastrous if you don't treat.
Of course, yeah. And also, it's known also the oral acyclovir is not crossing the blood-brain barrier. So I'm not sure.
Valcyclovir as oral, but it's better in this situation. You have to use an IV because the consequences are grave. So I would suggest IV antibiotics. And unfortunately, if you don't have swabs and you don't have CNS, and if you start acyclovir, even if you do lumbar puncture, it has no meaning because you kill most of the bacteria, and the possibility of PCR being positive is very low. So and these are one of the situations that we know it's acyclovir is effective. We know it's disaster consequences. So I would give antibiotic
right away.
Acyclovir for 6 weeks.
Thank you very much, very much.
You can use the IV, the oral, if you don't have IV access or your IV access is a problem.
And is it as effective as well?
It's effective, but it's not effective as IV, of course. But it's effective. It's effective. It is effective. So if you don't have IV access, if you don't have a surgeon to do the central line, for example, you can use the valcyclovir.
That's very useful. That's very useful. Thank you very much, Dr. Rehan.
You're most welcome. Remember to change your name next time from iPhone to real name.
I will. Thank you very much.
Thank you very much. Have a good one. Any more questions? No more questions?
Thank you, Dr. Rehan.
You're most welcome. I'm going to end now. Have a good day. Bye-bye.